quick, and I will try to keep it very pertinent here. All right, so I'm going to describe the risk factors for venous thromboembolism, describe prophylaxis, and then go over the 2008 CHEST guidelines that are sort of the current recommendations. We know the risk factors, Virchow's triad, we all learned that in medical school, but there's a variety of other risk factors. And if you look at this list, trauma patients have multiple of these factors, and they're additive. So as you start adding more and more, you'll see that the trauma population really is a very seriously at-risk population, obviously from their injuries, but also from their prolonged hospital stays and their need for often recumbency for periods of time. So what we know from Gertz in the New England Journal in '94 was that there's over a 50% rate of DVT in the trauma population if they're untreated, and it's the third leading cause of death after 24 hours in this population, is PE. So the time to start anticoagulation is usually within the first day to 2 days. This is when their bleeding risk goes down, but it's slightly before their thrombosis risk goes up. So how do we detect it? And this is the silent killer. I mean, this is the problem, right? So sometimes people will have shortness of breath or chest pain. Very often they don't. And so often what we'll see is we'll see somebody post-op day 1 or post-hospital day 2 that has tachycardia and they've got a fever, and that's it. And we start them down the PE workup, because a lot of times that tachycardia is all you'll get. As far as detecting it, contrast venography is not used that much, I don't think, anymore in most institutions. It's highly sensitive, but there's a non-diagnostic rate that's pretty substantial. It's painful to the patients, and there's contrast risk, as well as a risk of creating a thrombosis with the procedure. Doppler ultrasound is the detection modality of choice. It's universally accepted. It's portable. It has a low sensitivity for the small thrombi in the lower leg, but they probably don't have much relevance anyways. The issue is these pelvic veins. A lot of these clots are in the pelvic vein, and we don't have a great way to detect there. Some authors, Mike Bossi and Mike Stover and Dave Helfet, have looked at using MRV and also using a contrast CT to look at these areas, and the thought that maybe we could pick up these pelvic clots, and it really doesn't work very well. There's a high false positive rate, and they really have recommended against routine screening using these modalities. So these pelvic veins continue to be a diagnostic dilemma for us, and these are probably the ones that are the most significant and the ones that kill people. So what are the recommendations? So the College of Chest Physicians provide guidelines each year. The latest one was 2008. This was in the supplement. These are evidence-based review articles. It's an evidence-based review article that goes over an outline for all the fields as far as guidelines for treatment and prophylaxis. So 1A, what they call a 1A recommendation is a situation where the recommendations are strong, the benefits outweigh the risks and the burden of cost, and all trauma patients with at least one factor should receive prophylaxis. So that's pretty much every trauma patient. So what do we have? We have mechanical prophylaxis, chemoprophylaxis, and we have filters. And so mechanical prophylaxis, we have graduated compression stockings, we have foot pumps, there's some calf squeezers, there's a whole bunch of them out on the market. And the thought is it reduces venous stasis, there's no bleeding risk, and it maybe releases some endothelial factors that helps with clot prevention. But it's important to remember there's poor compliance. There's never been shown to be any reduction in the risk of fatal PE with the use of mechanical devices or death, so that's important to remember. We do use it as a useful adjunct, particularly in patients that have a bleeding risk, or that we use it as an adjunct with chemoprophylaxis. So what about low-dose unfractionated heparin? Because the general surgeons will sometimes try to float this in on these patients, and you need to know that this does not work. So the risk of using regular low-dose heparin in this population is equal to using no prophylaxis at all. Okay, it does nothing in the trauma population. And what you should use is low molecular weight heparin, which significantly is more efficacious for DVT prevention. So the low molecular weight heparins, they're easy to use. They're usually administered twice a day. You can use a once-a-day dosing, but most of the time we use a twice-a-day dosing. And in most patients, you can start within the first day and a half. There's contraindications. Obviously, if you have any sort of bleeding, uncontrolled bleeding, head bleeds, coagulopathy or perispinal hematomas, you need to hold off potentially on using it. Although, as people have gotten more and more comfortable using the low molecular weight heparins, I think a lot of these contraindications have diminished. So the recommendations from the chest group would be to start when safe. You should use mechanical prophylaxis if there needs to be a delay for some reason. And this is where it gets a little bit gray. You should continue your prophylaxis until discharge or if they're going to inpatient rehab. So those patients should stay on it. But it's unclear as far as which patients should continue on it afterwards. And this seems to be a big area where there is a secondary spike in getting a clot during this time frame and what to do with these patients. And so they don't really give you a lot of guidance. As far as a vena cava filter, it's has not been shown to be effective as prophylaxis. So there's really the indications for these, and the indications are trying to get expanded, I think, from the people putting them in, since there's a lot of retrievable filters that are now out there. But the indications really are if they have a proven DVT and they're contraindicated to receive full anticoagulation. So that's an indication for a filter. Or if they're going to be undergoing multiple surgeries and you're going to wind up with a lapse in your chemical prophylaxis, then that may be a reasonable indication. But you want to get these patients anticoagulated as soon as possible, even if they have a filter in place. So the chest group's recommendation was against the use of IVC filters as a primary prophylaxis. What about isolated lower extremity fractures? So these are fractures distal to the knee, okay? And so we have our standard risk factors of age, fracture, obesity, and patients undergoing surgery. And the risk increases as you get more proximal to the knee. So it sort of makes sense. So a plateau is an increased risk over a tibial shaft, which is over an ankle fracture. The interesting thing, though, is in an Achilles repair, a soft tissue repair, is equal to a lower extremity fracture. So they don't come down on one side or the other as what to do with these types of soft tissue reconstructions, but they throw it out there that it is a substantial risk, and you probably need to take those cases on a case-by-case basis. So the low molecular weight heparin does reduce the risk of asymptomatic DVT in these patients. It's unclear if it reduces the risk of important embolic disease. And their recommendations were against the routine use of thromboprophylaxis in the isolated lower extremity patient. Okay? However, well, I'll get to this. So, and the other comment that they talk about is they talk about Doppler ultrasound screening, and they recommend against routine screening. So, sort of globally screening all patients with Doppler ultrasound. They do recommend Doppler ultrasound in patients that are at high risk. So if you have a suspicion of a clot or swelling in the leg, you should get it. Pelvic fractures, multiple lower extremity fractures, indwelling femoral lines, or patients that have received suboptimal prophylaxis or no prophylaxis. That patient population, they do recommend the use of potential use of a Doppler ultrasound screen. So our protocol is all our patients get low molecular weight heparin unless it's contraindicated, and they get mechanical prophylaxis. As far as outpatient prophylaxis, so any of our patients that are going to get stage surgery, so calcs, pilons, plateaus that get spanned out, okay, and we want that person to be focusing on elevation for a 10-day to 2-week period. They go, even though it's isolated, because what we really are pushing them is to be recumbent with their leg up. We have send those people out on outpatient low molecular weight heparins. Obviously, if they're a multi-extremity, they get it and they stay on it until they become more mobile. If they're an isolated lower extremity injury, but for some reason they're going to be impaired in their ability to mobilize. They're big and fat, they've got upper extremity injuries, they're just have a risk of DVT, had a previous clot, those patients will go ahead and keep them on it. And also pelvic ring and acetabular fractures that are treated operatively, I like to keep them on something for about a 6-week period. A lot of times, from a logistical standpoint, it's easier to maintain the low molecular weight heparin for a 3-week period, and then I'll convert them to something else at that point. But you do need to remember that you need to monitor their platelets. There is an incidence of them having a thrombocytopenia that can develop, and that can be rather severe. And that's it.